As you know, the Senate has begun a distinguished speakers series every Monday to use our Senate floor, especially early in the year, to learn about an important subject. We're choosing subjects that are not highly partisan but are subjects that the membership as a whole can really learn something from. And today, it is my pleasure to introduce you to Sandra Goodwin-Naylor, PhD, to talk about California's mental health system. Before I introduce Dr. Goodwin, who has a PowerPoint here, I would urge members, I know you're all busy, but to stay if you would. As you know, this is a very important subject, not just to me, but I think to all the people of California, especially since the terrible events in Newtown. The public is talking a lot about mental health, but few are actually going the next step and addressing what do we do about helping people who are living with mental illness. The California story is complicated, but at the same time fairly well known to most Californians. Californians know this. I'm not giving away Dr. Goodwin's presentation here, that in the 1960s and 70s, the state made a well-intended public policy decision to shut state mental hospitals because the one flew over the cuckoo's nest was not really fiction. It was the truth. The idea was that people with serious mental illness could live in our communities with various degrees of independence and self-sufficiency with the right kind of community supports. And the story that I think Dr. Goodwin is going to tell us here today is what has happened since that well-intended public policy decision. What has happened to the commitment that then Governor Reagan and the Democratic legislature made to have the state fund 90% of the cost of community treatment? Where does the system stand today? What are we doing well? And where are the holes? Because I know I've talked to my caucus, and I know it's no secret to members like Senator Gaines and others on the Republican caucus, that we intend to make mental health care a priority in this legislative session. And today is I hope, a good foundation for the beginning of that discussion. Dr. Naylor-Goodwin is, I would say, the state expert on the subject. She is the founding president and CEO of the California Institute for Mental Health. 30 years of professional experience in the behavioral health field, both on the administration side, the treatment side. She understands service methodologies, planning and development, budget. She understands the state role, the county role. And I had the privilege of traveling back to Washington, D.C. With her. Actually, we met back there, where we made the case to our leaders in Congress and other national leaders. And she's been at this a long time, and I couldn't think of a better person to help educate the legislature on this important topic. Please welcome Dr. Sandra Naylor-Goodwin. Thank you.
Thank you. I really appreciate that, that introduction. I wonder if you could join me at my next family reunion and do that same introduction. That would be very helpful. Let me just tell you briefly who or what the California Institute for Mental Health is, so you know who you're talking to here or who's talking to you. The California Institute for Mental Health, I'm going to skip over there. The California Institute for Mental Health is a nonprofit organization. We operate all over the state of California, primarily working with and under contracts to state government, county governments, foundation support, and with community-based organizations. So very focused on the public mental health system in California. We do research, we do evaluation, training, and technical assistance, and our whole mission is around how do we improve health outcomes for the people of California by improving the behavioral health care systems. So let me just back up here. This is what I'm going to share with you today, And I think you have a copy of this PowerPoint, and I will tell you it is fairly detailed. I'm not going to spend a lot of time on all the detail on these slides, but I just thought in case you had a moment or two over the next couple of weeks, you might just want to have a great read and could go through all this. I'm going to talk about our public mental health system, what it looks like today. I'm going to talk about what we call the core services. I'm going to talk a little bit about the financing, and then I want to focus some of the changes that happened with Proposition 63, the Mental Health Services Act, and I'm particularly kind of excited to share with you some really successful work that's happening under that act. And then, of course, I will finish because we always have challenges, and I will share with you what some of those challenges are. So, our public mental health system, I want to give you just a sense of the scope and the structure. We have approximately, and we can only go by a lot of prevalence reports, and we also look at the California Health Interview Survey to try to determine how many people in our state actually are suffering from some kind of serious mental distress. And our approximation right now is about 1.6 million people in California. And I want to be sure that I'm clear. I'm not talking about that, I don't feel real great today. I feel a little down. I feel a little anxious. I'm talking about serious mental health distress to the extent that the person is having difficulty functioning in their everyday life. So 1.6 million people in California. How many do we serve in the public mental health system? Only about 600,000. So we're a fair way from treating all the people in need. That leaves about 1 million people left untreated. The good news is that a good many of those people will qualify under healthcare reform and the Medi-Cal expansion. And I've given you some numbers there. So about 250,000 more people will actually be eligible with the Medicaid expansion, people who have serious mental health conditions. Another 228,000 will be eligible for exchange health benefits, either subsidized or not subsidized. And about a little over 58,000 will be ineligible due to their lack of citizenship. Now that's only about 500,000 more people. So it still leaves another 500,000 somewhere in this state not being treated. And I will tell you generally where they are. They are the people who are on the streets that we have trouble reaching. They are people who are in jail. They are in prisons. They may be in our hospital emergency rooms. And the fortunate ones are somewhere with family members. But they're not eligible, they're not able to receive any treatment at all. So we have a long ways to go to actually fully treat the people in this state who need it. So the structure. Under the realignments that have taken place, and I'll talk about those a little bit more in a second, we have a state-county partnership. The state is basically in the lead. Most of mental health services responsibilities are within the State Department of Healthcare Services. And you can see up there, I've listed kind of generally the areas that the State Department of Healthcare Services is responsible for. You may remember that about a year or so ago, the State Department of Mental Health was eliminated. So now all of those services, for the most part, are provided by the Department of Healthcare Services. Then the Mental Health Services Act, and I will spend some time on that in a minute, also created something called the Mental Health Services Oversight and Accountability Commission. And that commission, again, has a whole series of responsibilities pretty specifically tied to Proposition 63, the Mental Health Services Act. A couple of other state departments have some responsibility. The Office of Statewide Health Planning and Development and the Department of Public Health. One of the important aspects about what's in the Department of Public Health is that that's where the Reducing Disparities projects are located, and they're very critical to actually reaching the people in the state of California. So now the county. Due to 1991 realignment, was anybody around in 1991? All right, I knew. Surely there were some of you who were around then. In 1991, most of mental health was realigned to the counties. So they got both the funding and the authority and responsibility for most of the mental health services. And then just in 2011, the remaining programs were realigned to counties. So essentially, you have the state with the oversight, governance, and accountability, and counties actually administering the services and accountable for those services, even though most of the services are contracted to organizations, the county is responsible. The other thing that happened in this realignment is that the substance use services for the state, which are unfortunately pretty minimal, were also realigned to counties. So basically, I want to go back and reiterate what Senator Steinberg said a minute ago, and that is one of the reasons we are so unable to provide services to all the people in need is that this system has been underfunded from the start. When the LPS Act passed, I won't ask you if you were here then. I'm assuming none of you were. That's right, only 1968. That was the act that provided civil rights to people with mental illnesses and also closed the state hospitals. And the intention was that that money was going to go to communities to take care of people in the community, but it didn't happen. And as a result of that, what we see so much on our streets are people with pretty serious mental illnesses and addiction problems living on the streets with nowhere to go and no services. Very serious problem that funding has generally increased over the years, but you need to put that into the perspective of how much our state has grown over the years. And there's been no ability of the mental health system to keep up with either the population growth or at one point in the 80s, which some of us remember, there was so much inflation that the dollars lost value. So I'm going to just give you a couple of pie charts. I'm not going to go into detail on them, but I want you to see in 10-11, the overall system was funded at about $4.5 billion, and that includes realignment, federal dollars, so counties use a lot of their realignment money and their Mental Health Services Act money to match for federal dollars under Medicaid. And this shows the Mental Health Services Act money, which was coming in at that point. And there are some other small pieces of dollars, but that's where the major funding comes from. So in 13-14, this is the estimate of what we're expecting in that year. And you will note it's going down, which is a surprise, but that's happened off and on. Realignment, the first realignment, did not keep up with growth at all. In fact, there were no growth dollars, so that money stayed flat for about 10 years as growth money went to other programs. And now we're seeing, again, just a slight drop. It's not huge, but it is a drop, and that's a problem. So now I'm going to talk about what we call our core services. And this was all set up in the Bronson-McCorquodale Act in 1991. I know 2 of you may remember that. In 1991, when realignment occurred, almost all the statutes in mental health were rewritten. And I just want to share with you this mission because it really became important in terms of what happened in mental health services after this point. So it talks about the focus being to enable persons experiencing severe and disabling mental illnesses and children with serious emotional disturbances. So what that said is that mental health programs were required to focus on the people who were most sick, who were most disabled, who really needed that kind of care and support. It defined target populations. So here are the target populations, essentially a diagnosis and a serious impairment connected to that for children, adults, older adults, and also counties were required to provide services after an emergency event. If there was a natural disaster or some kind of emergency and people were in need of mental health services in that aftermath, they're required to do that. What this meant is that some of the wonderful work around prevention and early intervention didn't happen. All we could do is focus on the most seriously ill. These are the services that are required, and I will point out it says to the extent resources are available. So that means whatever was allocated, whatever came through in realignment, that amount of money had to be spent on these services. And if there wasn't enough money to do all that was needed, then that's the way it was. One thing that's different about this is that for older adults, most of these services are required to be mobile, because we're assuming that a lot of older people who may be living in their homes not able to travel still need these services, so the services needed to be mobile. Okay, now I'm going to come to a change, and we have Senator Steinberg to thank for this. In 2004, Proposition 63, passed by the voters of California, enacted the Mental Health Services Act, and that made some real difference. Let me share with you what some of those differences are. It first of all said that mental health would be a priority. And then I'm going to look at the second line, because this became really important. Reduce long-term adverse impact from untreated mental illness. That really opened the door to begin thinking about prevention, early intervention, ways that we could maybe help people not become disabled, as opposed to just waiting until they were totally disabled to provide services. Oh, and we're still waiting for the second to the last bullet, provide funding adequate to meet the needs. We're still hopeful for that. Hasn't quite happened yet. These are the component parts of the Mental Health Services Act. I am going to talk a little bit about the prevention and early intervention, because there is some very exciting work happening there. But it also, this points out services to children, adults, and older adults. One of the things I want to point out here is it talks about transition age youth. And I don't know if you've been hearing about this, but one of the problems we have is that kids who go into foster care age out at age 18, and sometimes they've got nothing else to go to. And a lot of these kids end up on the streets, homeless, and with no assistance. So this act said we really need to pay attention to that particular age group. It also, this is where the Mental Health Services Act Oversight and Accountability Commission was established, and it also provides some funds for state administration and oversight of these programs. So this is the part I like. I get to talk about prevention here for a minute. And I think particularly because Senator Steinberg mentioned one of the things that we're very concerned about in the aftermath of some of the terrible school tragedies we've seen, starting with Columbine, Virginia Tech, and now most recently at Newtown, we really wanted to focus on what can we do in schools. So this is a program that's now operating in the state of California that you should feel very proud of. In 2002, and this is in the aftermath of Columbine and some of the other tragedies, the United States government, Health and Human Services, put out a report around what should schools be doing to prevent some of these horrible tragedies. And in this report, they said, you've really got to develop some preventative measures. You need protocols and procedures for managing and responding to threats and other kinds of behaviors. So this program started its pilot in Los Angeles County. It's now moving to Orange and Riverside. And we're hoping if these pilots continue to go as well as this first one, we're going to try to see if we can begin to move this program statewide. This program is called START, and it has these three purposes. First of all, to develop some partnerships to figure out what could be done to mitigate and eliminate these threats. And then once the students were identified who were in the middle of these problems, what do we do to help them so they can finish their education without incident? And definitely to try to prevent Columbine and Virginia type incidents. So this program starting in LA is a partnership with the mental health program, the Unified School District, and the Los Angeles Police Department. So they're all working together, and they work with schools to do these varieties of things. They do training and consultation, so they're out in the schools trying to help schools, teachers, counselors, others know what to look for with disturbed kids. And then once they're identified, then they can do early screening, and if that child does turn out to have some kind of an emotional disturbance, then the family is brought in and they try to develop an intervention program that's going to help that child. And last, once that intervention starts and treatment is in place, they do ongoing case management and monitoring, trying to make sure this kid gets through school without anything else happening, and hopefully moving on to a productive life. So here's the data we have so far. It's pretty exciting. About 4,000 kids have been screened. But this is the really, I think, great part. Schools identified 50 incidents of imminent threat of danger, where they really thought violence was going to happen on their school campus. And what they can do is they can contact the mental health department, who sends out a team consisting of mental health, police, and the school district officials to intervene on that campus directly with those kids. In all 50 of those, that imminent threat of danger, violence, was dissipated. And those kids were identified for services. What I'm waiting now, and I hope to have in about 6 months, is some data about what happens to the kids that were in the middle of these near-violent episodes. What happened to them, and did the treatment work? Did they stay in school? Are they doing well? That's what we're really hoping for. So now I'm going to move to early intervention, which is another excitement for me. I don't know for everybody, but certainly for me. To put this in context, we know, and I'm sure you all are aware of this, early detection and prevention in other diseases works. So we know in cancer, if we catch cancer in stage 1 and 2, that person's probably going to live. If it's later on, 3 and 4, they may more likely die from that disease. And we know with all kinds of cancers, the earlier we do the screening, the earlier we catch it, people have a much better survival rate. Now, why don't we do that in mental health? So look at this. These are shortened productive lives. The disease that creates the most lack of productive life is cardiovascular incidents. The second, you will note, is mental illness. More than cancer, slightly more than cancer, and more than the other diseases that are listed up there. So we really need to figure this out. And fortunately, there are some great programs happening. One of the things that we've learned, that even in mental illness, and I'm going to talk about schizophrenia for a minute because that's probably the most disabling mental illness, the shorter the time between when those first symptoms are identified and treatment begins, the more likely that person is going to recover and not continue on that disabling path of schizophrenia. If you look at these higher cognitive functions, these are the functions that we look for. So we're looking for, and this starts at a very young age, and usually it's the parents or maybe it's the school who sees it. If you don't know that person, you may not notice it. But if it's your child or your student, you may notice that their attention is wavering. They're no longer able to focus. Their memory is fading. They're having language disturbances. They're using words in a strange way. And as it progresses, then that person is less able to even process emotional events, what that really means emotionally. And then pretty soon, if it keeps on going, you're going to look at the person's going to start having hallucinations, either auditory voices in their head or seeing things that aren't there, or delusions, just misperceiving reality. So what these programs are now doing is by early identification, they're finding that 90%, which is huge, 90% can respond to this early treatment. So here's a program right here in your backyard, UC Davis. This is a partnership between UC Davis and Sacramento County Mental Health Department using Mental Health Services Act dollars. They are participating in a controlled study that's a nationwide study. It's all over the country. They're focusing on people 12 to 25 years old. And they've been doing education with schools. They're trying to get information out to the general public so family members can begin to recognize this. And by bringing them in, they then provide 2 years of very intensive family-focused, family-aided treatment. And it's working. I'm going to show you a little bit about how that's working. So here's Ventura County. This is their program. They're not part of this big national study, but they've looked at it and they said, well, we want to do that. So they're focusing on kids 16 to 25. They spend 2 years working with this family the entire family. And here's the outcomes. I think this is really exciting. So take a look at this. The baseline means when this child or person was identified. So it starts out, only 14% of them were working. 6 months later, 70% are working. And a year later, 83% are working. That's huge, because schizophrenia, just to be clear, is a disabling disorder. The person starts out here, they have their first psychotic episode, and their functioning deteriorates. They have another one, and it deteriorates. Another one deteriorates. So pretty soon that person is not able to function at all. And with this kind of a program, I'm not going to go through all of these outcomes with you, but I think they're really incredible. And looking at the graduating from high school, for example, started out 43 had managed to graduate, 6 months later 70%, a year later 75%. Those are really huge outcomes for such a disabling illness. And the average score, that just means their general functioning score. It goes from 42% to 72, a score of 72. Really impressive. And these are people who, if untreated, would likely become disabled in their lives. So here's more. One of the concerns is, can we really stop this episode of psychosis? And what this shows you is that yes, at baseline, 67 of them were slowly sliding into a psychotic state. At 6 months and 1 year, 0 were in a psychotic state. And then the hospitalizations from 29% to 0, the number in incarcerated, that's mostly in juvenile justice, went from 14 to 5%. Suicides, there were none to start with, but there were 16% suicide attempts, and at the end of this treatment, 0. So that's why I'm excited about this. I think it's wonderful, and we need more of these kinds of programs throughout our state. All right, now I'm going to just skip, and this is my last piece, and then I'll tell you very briefly our current challenges, and then I will stop because you probably have something else you need to do this afternoon. Full service partnerships. The slogan is whatever it takes. And these are for the people that are already disabled. So they're already either homeless or at risk of homelessness due to their mental disorder. We have treated about 60,000 total people in these full service partnerships. And when I say full service, I mean it is a team of people that is available 24 hours a day, 7 days a week to assist this individual because their life is kind of an ongoing series of crises. This study that I'm citing here came from UCLA. Just recently did a study on these full service partnerships. First of all, they found that these people actually had dramatically improved lives. So remember, they're homeless or at risk of homelessness. The very first thing they do is try to get these people into a stable living environment. Can you imagine trying to help someone in any fashion who's living on the streets in fear all the time? It doesn't work. You've got to get them into a stable, some place to live where they feel safe, and then you can start working with them. So this is interesting. We were hoping this would be the case, and it turns out to be true so far. For every dollar that we spend on these full-service partnerships, we save 88 cents. So it's almost not quite paying for itself, but close. And this comes from not being in the emergency room, not being in the hospital, not in long-term care, not being arrested, not in the jail, not in prison, and not in juvenile hall. So all of those things get turned around with this work, and those are the numbers of the savings thus far. I just want to give you a visual picture. So this is the number of days that this population, and this is just looking at one, in fact, this is Los Angeles County. They have great data, so I always go to Los Angeles to get their data. Here they had about a little over 94,000 days spent homeless before they were part of this program. After they're in the program, it's down to about 28,000. So just want to give you a visual picture of the change that happens for these folks in full-service partnerships. And then here's another one. This is going from not living independently to living independently, another significant change. And this is the days not spent in jail. So that first pillar, almost 20,000 days spent in jail, and the last one is about 6,000 days spent in jail. Big changes. And just so you know, again, I'm using LA's data. These aren't just adults. So some of them are children. That transition aid youth population I talked about earlier, adults, and even older adults are in these programs. All right, my last piece, and then I'm going to stop, see if you have any questions, and then let you go on without your many pieces of business you have to do today. So one of the things I've been asked all the time is, so what are the challenges today? What is it that if you could wave a magic wand and say what the mental health system needs and get it, what would you ask for? So one of the things that we're really focused on right now is something called mental health first aid. That is a training program for the general public. It is a training program to help you understand a little bit about what mental illness is and what to do if someone you know, care about, is experiencing these symptoms and how to get help. And I will tell you that we even did this for our staff, our operations staff, who don't work in mental health, and they were amazed at the end of that because they were saying, you know, I didn't understand this very well before, and now I do. People feel really good about it because it gives them tools for what to do. And our hope is that at some point, this will be as common as CPR. It's just another way to save lives. The school screening and intervention I talked about, boy, we need that. We need that in every, if I had a magic wand, we'd have it in every school in California. The early intervention programs I talked about, we have about 6 of them right now around the state. Some of the Bay Area counties are looking at how they can start some, but we really need those badly because we could change lives by having those early intervention programs. We don't have enough hospital beds in this state, but we also have learned that crisis residential is a less expensive and often more effective way to handle psychiatric emergencies. So we have some across the state, not enough. We need a statewide comprehensive evaluation system. I've got tons of evaluation material that I could share with you, but none of it comes together to tell you, the policymakers, or anyone else, what's happening across this state. And we really need that overall comprehensive evaluation program. We recently interviewed about 35 stakeholder kind of advocacy groups. Every single one of them said we need this. We need to increase the numbers of evidence-based practices we have in the state. We have found that evidence-based practices, and with all kinds of ethnic populations, not just Caucasian populations, these work very well. So we need more of an emphasis on that. And shall I mention healthcare reform? That's coming right up, and we're working a lot on how to integrate mental health, substance use, and primary health care into one system, and we need a lot more of that work. Programs are working really hard on that, but it is tough, and we need more tools to help these organizations move forward. Our workforce is probably not adequate. Remember I showed you that one chart? We're going to have another 500,000 people eligible for services. There's no workforce for that. We need to work on that. And the last thing would be the infrastructure. Some of our programs, and especially in the substance use area, are little mom and pop organizations who maybe are in recovery themselves and they really care and they're doing great work, but if you ask them how to do a Medicaid billing, they don't know. We need a lot of infrastructure work to make sure we don't lose the programs that we have because they're limited, and they do amazing work that you've got to really bring your heart as well as your mind to in order for it to work. So with that, I'm going to stop. Those are, I think, our current challenges. Be happy to entertain any questions. I'd also be happy to just stop and
I want to thank the Senate Pro Tem for having you here today and appreciate the information that you've provided. And what I find very interesting is the early intervention aspect of this. And I think the public awareness and how important that is for our society to kind of understand the challenges of mental health and knowing how to identify that maybe within a family or with friends so that proper action can be taken. And the treating of this as a disease, I think, is so critical for our society to understand that mental health, many of these issues are a disease, right, and they're treatable, and how important it is to have that early intervention, just like any other disease, that you can attack it and take corrective action. So thank you so much for the presentation.
Oh, thank you. It's a privilege to be here and to share this with you. Okay, thank you.
No, not done.
No, okay.
No. Thank you. Again, thank you for coming, Dr. Naylor Goodwin. You know, big picture again, we talk about challenges today and the gaps that exist in the system. And you had an earlier slide that said the full service partnerships, for example, whatever it takes, have served 60,000 people. And I know they're not just homeless people, some of them are. They're emancipated foster youth, they're the shut-in elderly. The counties, of course, define their priority populations, but it begs the number one question that I know we get asked in our communities all the time. The family member who has either a child, but even more compelling, or not more compelling, as compelling, an adult child who is living with serious mental illness in, you know, stereotypically in kind of the back bedroom, where the family may have insurance, probably does have insurance, but they don't know what to do. Now, the full service partnership, we know from not just the people that we've met, but from the early evaluations, work to help people recover. But even helping 60,000 people, we know that there is a huge gap between the resources available to be able to serve that many people and the number of people who need help. What is that gap? How large is it?
Well, the numbers that I shared earlier, I just want to repeat them because our estimates are that about 1.6 million people in California have serious mental illnesses. And we are treating about 600,000 of them. That leaves 1 million people untreated. With healthcare reform, about another 500,000 people will be eligible either for expanded Medicaid or the subsidized insurance. I need to point out that if a person already has a serious mental illness, it's not an easy thing for them to enroll. So we're going to have to do special enrollment to try to get people into services. But that still leaves another, even if all of those people got services, theoretically, ideally, they all got services, we'd still have another 500,000 people that aren't getting anything at all. So it's a pretty significant gap.
Follow-up question. When we started in this work back in 1999, when I know I introduced my first bill to form the programs that are the basis for the full-service partnerships, my joint author on the bill was Scott Baugh, then the minority leader. Bipartisan issue is my point, because this issue crosses all lines and sectors of society. It knows no party affiliation or race or class or community. And Prop 63 was intended to build upon an already insufficient base of funding to be able to create a new system and help more people. And there's a lot of frustration out there because as much as it is doing, as you've evidenced, it's not enough. Can you just explain budget-wise again? I know you have the one chart here that shows that now MHSA Prop 63 funding is more than realignment, but what's happened to the pre-existing system funding-wise since Prop 63 passed? Because I think that's an important...
One of the difficulties is because it started out so underfunded when the state hospitals closed, that money didn't move, realignment helped to stabilize, and I hate to admit it, but I was around way before that. I was actually a county director at the time, and every year we cut our budgets, because at that point, mental health was the largest unconnected item in the budget. That it wasn't caseload driven, it didn't have some other requirement, so it would get cut every year. So during the 80s, we cut every year, went down, down, down. Realignment was an attempt to stabilize it, and it did for about 2 years, and then after that, the growth went to all the other programs. It did not go to mental health. So for about 10 years, again, there was no additional funding, just that one realignment amount of money, and our population continued to grow. So, you know, if we started underfunding, we just kind of kept dropping further and further down. Frankly, if the Mental Health Services Act hadn't passed, I don't even know what kind of system we would have today. I would only want to think about it.
No, thank you. But what's happened since '04, even during the last great, it's not the word great,
The realignment
last
funds,
recession?
Yeah, the realignment funds have continued to drop. The population has grown, and with the recession, the need has continued to grow. So it's just, you know, it's a sad tale. The funds get worse and worse, the need grows and grows. So we have a very significant and serious gap. The exciting thing is we have programs that work that I was just showing you all. We don't have the funds to do them all over the state. We just don't have it.
Yes, I don't know if you addressed this, but I'd be interested to know if there's something we might do on the front end of this. I have several friends who are counselors, therapists, PhDs, and they seem to feel that things are getting worse, and that the incidence of mental illness is growing, and that we don't seem to have the social infrastructure to deal with it, not just in terms of assisting people, but is there something that we should be looking at as a society to try to deal with mental illness before it happens? In other words, are some of our institutions, our social institutions, failing us? Are there things that we can be doing to prevent mental illness from occurring? Or, you know, it almost feels like our social infrastructure is kind of frayed, and we're not keeping people together. We're not dealing with problems before they become serious enough to define as mental illness, or is that just the nature of society and we're just starting to recognize what mental illness is?
You know, that's one reason I shared with you the school-based prevention and the early intervention, because there really is a lot that can be done to stop that progression of mental illness. I think the more we can work closely with schools, and remember, every one of these treatment programs I'm talking about become family-based, because it is the strength of the family that's going to support that individual in the long run. So even though the source of the intervention or the identification might be at the school level, it's always going to be working with the family. And there are highly, highly successful programs that can do that. And I talked about the early intervention. We have 6 of them in the state. We need those all over the state. They're relatively expensive, but what I'm looking forward to is the research that looks at what the long-term cost savings is, because if we can prevent these people from becoming disabled and they have productive lives, we're not just saving that person's life, we're saving huge amounts of money. But I do think that school-based and churches too, I didn't mention that. We work a lot with churches, and a lot of churches are taking the mental health first aid training, especially the pastors. They're really interested in that so that they can understand and know what they can do and when they need to get help. So I think there's lots of ways to do this. We just need to really get thoughtful about doing it in a comprehensive way, rather than I can tell you about this program and that program and that program. We need them across our state.
The federal government just released their breadth of services for the essential health benefits, and mental health was listed as one of them. Okay. This came out last Wednesday, and it identified that they have to treat mental illness equal to other illnesses in terms of the essential health benefits, and not require the state government to reimburse the cost of doing so. And I wanted to ask you, what can be done to improve private insurance coverage of mental health given that new ruling?
Enforcement. There are laws currently on the books. There was an earlier federal parity law that's supposed to impact health insurance. I don't see enforcement taking place in this state other than when an individual complains to Department of Managed Care about their specific health plan and the fact that they're not offering mental health or substance use treatment at parity. So I think enforcement is really important, and then it's going to be very important for all of us to carefully look at the benefits as they get developed through Covered California, our health exchange, to make sure that they are actually addressing mental health and addiction services at parity with the rest of healthcare. And I could, we have a whole series of what we call the business case for parity, because if you provide behavioral health care services, you reduce overall healthcare costs. And that's another whole long story, but there's a lot of that information. But I think both the enforcement, having a state agency really take charge of that, and looking carefully at the benefits as they get developed through the Covered California are crucial. Thank you for that question.
And very,
Thank
very
you.
informative. We really appreciate it.